Sometimes you think you understand a topic, but then you dig in and realize, wow, there's so much more to it.
Absolutely.
Today, we're doing just that, a deep dive into drowning and submersion injuries. It's a really significant issue globally and right here at home.
It really is. And if you're tuning in to get a solid, quick understanding, you're definitely in the right place.
Yeah, we've gone through a pretty detailed medical review from UpToDate, also some insights from a trauma unit document.
Our goal is really to pull out the critical info, clear up some, confusing terms you might hear, and maybe highlight a few surprising things along the way.
Exactly. Think of it as our mission. Give you a clear picture of what drowning actually is,
Hmm.
why it happens, how it affects the body, and importantly, what works in terms of management and prevention. And we'll definitely be ditching those outdated terms.
Sounds good. Where should we start? The sheer numbers.
Let's do that.
Yeah.
The scale of the problem is, well, it's sobering. Globally, we're talking at least 360,000 deaths every single year. And here in the U.S., it's around 5,400 deaths annually. But, and this is key from our sources, the number of non-fatal incidents, way, way higher.
That's a crucial point. Those non-fatal events often lead to serious, sometimes lifelong health issues. It really underscores why this is such a major public health concern worldwide.
It really does.
Okay.
So let's tackle the language. This seems to be a big area of change.
Yeah, terminology has definitely evolved. There's been a real push for clarity and consistency.
So terms people might be familiar with, like near drowning or secondary drowning.
Those are out, basically obsolete in the medical community now. Same goes for wet versus dry drowning. It just wasn't helpful clinically.
Okay, so what is the accepted definition then?
It's actually quite straightforward now. Drowning is defined as the process of experiencing respiratory impairment from submersion or immersion in liquid.
Just that, focused on the breathing being affected.
Exactly. The core issue is that respiratory impairment.
So if that process leads to death, it's fatal drowning. If the person survives the respiratory issue,
Then it's non-fatal drowning. Simple as that. And the WHO, the World Health Organization, is even suggesting ways to classify how severe the non-fatal drowning is.
right, I saw that, like mild, moderate, severe impairment based on consciousness and breathing difficulty.
Yeah, gives a bit more nuance to the non-fatal cases. And we should also quickly define rescue.
Okay, what's a rescue in this context?
A rescue is when someone is submerged or immersed, but someone intervenes before they actually develop any breathing problems, so stopping the process entirely.
Got it. Preventing the respiratory impairment from even starting.
Mhm.
Okay, so who is most affected? Let's look at the epidemiology.
Well, globally, it's a leading cause of accidental death, especially for children. And something really striking is that over 90% of these deaths happen in low and middle income countries.
90%. That disparity is huge.
Hmm.
Makes you think about access to things like swimming lessons or just safe water areas.
Absolutely. And even within the U.S., the stats are concerning.
Hmm.
For every child fatality from drowning, 7 others end up in the ER.
And 40% of those kids need to be hospitalized. That's significant.
It is. It's a major cause of accidental death for people under 45 here, and particularly for kids under 5, especially if they live near water.
What about demographics? Any patterns there?
Definitely. We see higher rates in males, also disproportionately higher rates among African Americans and Native Americans, which points towards potential systemic issues.
And young children, 1 to 5 years old, are a key group,
Mhm.
often linked to supervision lapses, right?
Exactly. Lack of adequate adult supervision is a huge factor there. Lower socioeconomic status, living in the southern U.S., these also emerge as risk factors in the data.
And sadly, the sources mentioned about 7% of childhood drownings might involve abuse or neglect.
That's a really tough statistic. For adults, drownings often happen in water lakes, rivers, oceans, and peak in the summer months, which makes sense.
There was some interesting Canadian data, too. Median age was 44, mostly male, often alone during boating or swimming in lakes or rivers.
Yeah, and about a third had pre-existing health conditions, things like heart disease or seizure disorders.
Which brings us nicely to the specific risk factors. It's not just about not being able to swim, is it?
Not at all. Though inability to swim or conversely, overestimating your ability is definitely on the list, but inadequate supervision, especially for kids, is critical.
Being alone near water, too.
Right. Risk-taking behavior, you see that more in teens and young adults. And then there's alcohol.
The alcohol link seems really strong.
It's undeniable, involved in over half of adult drowning deaths. And get this, a high blood alcohol level, say 150 milligdl or more, increases your fatal drowning risk by 37 times.
37 times. Wow, that's staggering.
It really is. We already mentioned the higher rates in Black American and Native American populations. Hypothermia is another risk. Getting too cold impairs your ability to swim or stay afloat.
And sometimes drowning happens alongside something else, like a fall, a stroke, maybe a heart attack.
Exactly, concomitant events. And specific medical conditions really elevate the risk too. Seizure disorders, for example, nearly a 20-fold increased risk in kids and adolescents.
20-fold.
Yeah, developmental or behavioral disorders in children too, and even undetected heart rhythm problems, like certain genetic conditions affecting cardiac channels. The sources mention RYR2 gene mutations.
That's fascinating, the underlying cardiac link. And what about hyperventilating before a dive? I remember hearing that was dangerous.
It is. Hyperventilating intentionally before swimming underwater blows off too much carbon dioxide. CO2 buildup is what normally triggers your urge to breathe.
So if you lower it too much.
Your oxygen can drop to dangerously low levels before you feel that urgent need to surface for air, leading to blackout underwater, hypoxic blackout.
Right, a real danger. Okay, so what's actually happening in the body during drowning? The pathophysiology.
It typically starts with, panic, irregular breathing, trying to hold your breath, then that overwhelming feeling of air hunger, struggling.
And then the body just forces a breath.
Yeah, eventually there's a reflex gasp, an inspiratory effort, and that's when water gets aspirated into the lungs, causing coughing and choking.
How quickly do things go downhill from there?
Very quickly. Hypoxemia, low oxygen in the blood, develops rapidly. This leads to loss of consciousness, and then breathing stops altogether, which is apnea.
And cardiac arrest follows.
Usually, yes. It's typically caused by the severe lack of oxygen. Interestingly, in drowning, the heart rhythm often degrades into bradycardia, a very slow heart rate, and then pulseless electrical activity, or PEA, not usually the chaotic ventricular fibrillation you see in, say, a sudden heart attack.
So the key damage is from the brain being starved of oxygen, cerebral hypoxia.
That's the main driver of morbidity and mortality, absolutely.
What about the water itself in the lungs? Does it matter if it's salt water or fresh water? How much water causes problems?
It turns out the amount of fluid is more critical than the type. Even a small amount, like maybe 1 to 3 milliliters per kilogram of body weight, is enough to wash out surfactant.
Surfactant. That's the stuff that keeps the air sacs open.
Exactly, like a detergent lining. Without it, the air sacs collapse, making gas exchange incredibly difficult, leading to respiratory distress.
But are there any differences between salt and fresh water effects?
Well, both cause lung injury, that's the main thing. Very cold water submersion can sometimes trigger ventricular arrhythmias. Some older data suggested worse cardiac arrest outcomes with salt water, but that's likely confounded by other factors. And of course, heavily contaminated water brings a higher risk of lung infection.
Okay, let's break down the effects organ by organ. What's the primary impact on the lungs?
So, as we said, fluid aspiration washes out surfactant, damages that crucial barrier between the air sacs and the blood vessels, the alveolar capillary membrane. It becomes leaky.
Leading to fluid buildup in the lungs.
Right. Non-cardiogenic pulmonary edema. Basically, fluid in the lungs not caused by heart failure. In severe cases, it progresses to ARDS, acute respiratory distress syndrome.
And that causes the low oxygen levels, the hypoxemia.
Yes, through a combination of things. The lungs get stiff and hard to inflate. There's a mismatch between where the air is going and where the blood is flowing, VQ mismatch, and blood bypasses the damaged areas entirely, which is called shunting.
So salt versus fresh water isn't the main clinical concern for the lungs.
Not really. The injury pattern is similar. Importantly, symptoms might develop over the first, say, 8 hours. If someone seems okay initially but was submerged, they need monitoring. Chest x-rays or CTs can range from looking normal to showing widespread edema.
And the brain. Neurological effects are obviously a huge concern.
A major concern. About 20% of non-fatal drowning survivors have some neurological damage from that hypoxic ischemic injury. It can range from subtle cognitive issues to tragically severe disability or a persistent vegetative state.
Is brain swelling always a factor?
Significant cerebral edema or increased intracranial pressure usually indicates a very severe initial injury. It can sometimes develop or worsen around 24 hours post-event. Seizures are also possible, including non-convulsive ones you'd only pick up on an EEG.
And the initial neuro exam might not tell the whole story.
Exactly. Things like hypothermia or intoxication can confound that initial assessment. So prognosis based purely on the first exam can be tricky.
Okay, what about the heart and cardiovascular system?
The effects there are mainly driven by the hypoxemia and, if present, hypothermia. You can see various heart rhythm problems, dysrhythmias.
The not typically VFib, like we said.
Right. Ventricular tachycardia or fibrillation are less common in pure drowning unless there's underlying heart disease. You can see ECG changes that look like a heart attack, but they might be due to stress, cardiomyopathy, coronary spasm, or just the effects of cold and low oxygen.
And that cold water connection you mentioned earlier.
Yeah, swimming or diving in cold water, especially with breath holding, can trigger fatal arrhythmias in susceptible people, like those with long QT syndrome. It's thought to be due to conflicting signals from the autonomic nervous system.
An autonomic conflict. Interesting. Any other cardiovascular points?
Cold exposure can also cause cold diuresis, basically. You pee more, which can lead to hypovolemia, low blood volume, and potentially hypertension.
Makes sense. What about other systems? Kidneys, blood?
Acidosis, both metabolic and respiratory, is pretty common due to the lack of oxygen and impaired breathing. Major electrolyte problems are actually rare unless maybe someone drowned in, like, the Dead Sea with super high salt content.
Okay.
Severe cases can definitely lead to multi-organ dysfunction. Kidney injury, like acute tubular necrosis, can happen from the lack of oxygen, but it's not super common. Significant hemolysis or clotting problems are also rare.
Right. Let's pivot to the immediate response. What should a bystander do if they witness a drowning?
Acting fast is absolutely critical. It dramatically improves outcomes. If the person isn't breathing or has no pulse, start CPR immediately.
And for drowning, conventional CPR with rescue breaths is preferred.
Yes, because the primary problem is lack of oxygen. So start with breaths if you're trained and willing. If not, compression-only CPR is better than nothing.
What about trying to get water out? Heimlich maneuver. Turning them upside down.
No, absolutely do not delay rescue breaths or compressions for those maneuvers. They aren't effective and waste critical time.
Okay, so focus on breaths and compressions. What about checking for a pulse?
Check briefly, but don't spend too long on it, especially if you're unsure. Breaths are crucial. Starting compressions is key if they're unresponsive and not breathing normally.
Is it possible to do CPR in the water?
Rescue breathing, maybe in shallow water or once you get them to a stable surface. Chest compressions are basically impossible in deep water, maybe feasible on a boat deck if trained. Get them out of the water onto a firm surface ASAP.
Use an AED if one's available.
Definitely. As soon as possible. Dry the chest first, then apply the pads and follow the prompts. If it advises a shock, deliver it.
And if they are breathing on their own.
Give high-flow oxygen if you have it available. Keep them warm.
What about managing the airway before paramedics get there?
If someone isn't breathing, or is struggling significantly, or can't protect their own airway, intubation, putting in a breathing tube, is the gold standard, but that requires trained personnel and equipment.
So what can be done otherwise?
Using a bag valve mask, a BVM, or potentially a supraglottic airway like an LMA can be effective ways to ventilate until more advanced help arrives. Using a HEPA filter is recommended if there are concerns about airborne infections.
And keeping the patient warm is important.
Very important, especially if they're hypothermic, like below 33 Celsius core temp. Remove wet clothes, cover them up. Active rewarming might be needed later.
Cervical spine. Neck brace.
Not routinely needed unless there's a clear mechanism like diving into shallow water or obvious signs of injury. Immobilization can sometimes hinder airway management.
Okay, now let's shift to the hospital setting. What if the patient arrives in cardiac arrest?
The big principle, especially with hyperthermia, is you're not dead until you're warm and dead. Continue resuscitation efforts while actively rewarming the patient.
How warm do they need to be?
The target is usually a core temperature between 32 and 35 degrees Celsius. Resuscitation typically continues until they reach that temperature and have been in a systole flatline for at least 20 minutes despite ongoing efforts.
So potentially very long resuscitation times.
Yes, especially if hypothermia was significant before the arrest or the water was extremely cold, like below 6 Celsius. There are reports of successful resuscitation after 60, even 90 minutes in those scenarios. Poor outcomes are more likely if ROSC return of spontaneous circulation doesn't happen within about 30 minutes of ALS starting, unless there's that significant preceding hypothermia.
What about ECMO? Extracorporeal support.
ECPR, which is ECMO plus CPR, can be a salvage option in centers that offer it if conventional CPR fails. Outcomes seem better if the initial core temp was very low, maybe below 26C, and potassium levels are normal.
And after they get a pulse back, ROSC, temperature management.
Yes, for patients who aren't following commands after ROSC, targeted temperature management, or TTM, is often considered, maintaining a core temp between 33 and 36 Celsius for at least 24 hours.
Does TTM definitely improve outcomes in drowning?
The evidence specifically for drowning isn't as strong as for other causes of cardiac arrest. It's debated, and there might be a slightly increased risk of sepsis. But importantly, you absolutely want to avoid hyperthermia, letting their temperature get too high.
Okay, what about managing patients who arrive with a pulse but are still sick?
The focus there is supportive care. ABCs, airway, breathing, circulation remain paramount. Intubate if needed, maintain cervical spine precautions if indicated.
What kind of monitoring?
Continuous pulse oximetry, cardiac telemetry, end tidal CO2 if they're ventilated, and core temperature monitoring if they're hypothermic or undergoing TTM.
What about common issues like bronchospasm?
Treat that with inhaled beta agonists like albuterol. Prophylactic antibiotics generally aren't recommended unless the water was obviously grossly contaminated, like sewage.
What initial tests are usually done?
Core temp, blood gas, often arterial ABG, chest x-ray, ECG, maybe cardiac enzymes like troponin if the ECG is abnormal, basic labs like electrolytes, kidney function, liver function, CBC, clotting times, PT, alcohol level usually unless it's a very young child, bedside glucose, and imaging to rule out other injuries, a brain CT if their mental status stays altered, maybe a bedside ultrasound, an EFAST exam.
Let's zoom in on managing hypoxemia, the low oxygen.
Right. The goal is support oxygenation and ventilation. We intubate if their neurostatus worsens, if they can't protect their airway, if they can't keep oxygen sats above 90% despite high-flow oxygen or non-invasive ventilation, NIV, or if they're showing signs of tiring out, ventilatory failure.
And if intubated?
Place an orogastric tube to empty the stomach. Use lung protective ventilation, low tidal volumes, adjust PEEP as needed to improve oxygenation. Avoid letting CO2 levels get too high if there's concern for brain injury.
What about non-invasive ventilation like CPAP or BiPAP?
It can be helpful for some patients who are awake and cooperative, but you have to watch them closely for worsening condition, potential hypotension, or aspiration risk.
Is bronchoscopy needed?
Not routinely, only if you really suspect they inhaled a foreign object.
And ECMO again?
Venovenous ECMO might be an option for refractory hypoxemia in specialized centers if the patient didn't have a super prolonged arrest or severe acidosis or kidney failure beforehand.
How long does the lung injury typically last?
The good news is it's usually reversible. Most patients without cardiac arrest recover well. Mild injury might just need oxygen for a day or two. More severe cases needing NIV or intubation might need that support for at least a couple of days while the surfactant regenerates.
When are antibiotics used for the lungs?
Usually only if there's clear evidence of pneumonia developing a couple of days later, fever, high white count, new infiltrate on x-ray, or if the drowning occurred in sewage or similarly contaminated water. Then you'd target specific waterborne bugs.
Okay, what if someone survives but has persistent altered mental status?
You have to suspect hypoxic ischemic brain injury or perhaps non-convulsive seizures. The focus is preventing secondary injury, maintain oxygen, normal CO2, good blood pressure, control pain and agitation, correct any metabolic issues,
Head elevation.
elevate the head of the bed to 30 degrees, assuming no spine injury and stable blood pressure. If there are signs of herniation, you might use temporary measures like hypertonic saline or mannitol, maybe brief hyperventilation as a bridge.
Seizures.
Get an EEG to check for non-convulsive status. Treat any seizures aggressively, preferably with non-sedating agents. Keep the patient adequately sedated, but try to avoid paralysis if possible so you can still do neuro exams. Maintain normal temperature unless doing TTM, and normal blood sugar. Be careful with fluids, treat overload, but avoid dehydration. And watch for that potential delayed cerebral edema around 24 hours.
How is hypotension managed? Low blood pressure.
Start with 5U fluids, crystalloids, to counteract that immersion diuresis and other potential causes. The EFAST ultrasound can help assess fluid status and look for bleeding.
And if fluids aren't enough?
Then start vasopressors like norepinephrine. If hypotension persists, you might need to investigate further for cardiac dysfunction, maybe with an echo or even a pulmonary artery catheter. Treat any unstable heart rhythms causing the low pressure according to standard ACL SPILS protocols.
And rewarming for hypothermia.
If the patient is awake, passive rewarming, blankets, and active external rewarming, forced air warmers, is the way to go after removing wet clothes. If they've had ROSC and have severe neuroinjury, TTM might be the goal, keeping them between 33-36C. If they're unresponsive and below that TTM target, they might need active internal rewarming, warmed IV fluids, or more advanced methods like endovascular cooling warming catheters, or even ECMO for rewarming in specialized centers.
Okay, so after all this, how do you decide who goes home and who needs to stay in the hospital? Disposition.
Right. If someone was submerged but had absolutely no symptoms, normal oxygen, normal vitals, and remembers everything, they can potentially go home with a responsible adult and clear instructions to return if any symptoms develop.
What if they did have symptoms, like coughing, but seem better now?
Those patients need observation, typically for at least 8 hours. They can potentially go home if by the end of that period they are completely back to their normal mental state. Respiratory symptoms are gone or clearly resolving, vitals are normal, they don't need oxygen, and their lung exam is clear.
Because symptoms usually appear within how long?
Usually within the first 7 hours or so, so an 8-hour observation period is generally considered safe. Again, clear return instructions are vital.
And who definitely needs to be admitted?
Pretty much anyone who is hypoxic, had witnessed apnea, had a dysrhythmia, has an abnormal chest x-ray, required significant intervention like resuscitation or intubation, or had prolonged unconsciousness needs admission. Basically, anyone significantly ill or at risk of getting worse. The duration of submersion and severity of the initial hypoxic insult really predict how they'll do and how long they might need to stay.
You mentioned the sources also touched on therapies that don't work or are investigational.
Yes, important to note. Glucocorticoids, steroids, haven't shown benefit for drowning-related lung injury. Routine intracranial pressure monitoring isn't generally recommended as it hasn't improved outcomes. Exogenous surfactant replacement sounds logical, but evidence doesn't support its routine use. And things like barbiturate comas haven't consistently shown benefit either.
Okay, so predicting outcome, prognosis. What are the key factors?
Submersion duration is probably the single most critical factor. Less than 5 minutes is associated with much better outcomes.
And poor prognostic signs.
Submersion longer than 5 minutes, taking more than 10 minutes to start effective basic life support, needing resuscitation for over 25 minutes, being older, over 14, arriving with a very low GCS score, still being apneic or needing CPR in the ER, and having severe acidosis, pH 7.1 on arrival.
But it's hard to know for sure early on.
Very hard. There aren't really validated predictors to say stop efforts definitively early on, especially with potential hypothermia. Significant neurological recovery is possible even after prolonged submersion sometimes. But absence of spontaneous, purposeful movement at 24 hours is generally considered a very poor sign.
What about the cold water effect? Protective.
It's debated. Some studies suggest it might be, especially if submersion is under 6 minutes and the person is younger, but it's not a clear-cut protective factor in all cases. Drug or alcohol involvement generally worsens the prognosis, and resuscitation standards have changed over time too, so older data needs context.
This whole discussion really hammers home the importance of prevention.
Absolutely. Drowning is largely preventable. It sounds simple, but things like proper four-sided pool fencing with self-closing gates, constant focused adult supervision for kids near any water.
Even bathtubs, buckets.
Exactly. Swimming with a buddy, using life jackets, especially when boating, and avoiding alcohol and drugs completely when you're involved in water activities.
Crucial points. Resources from places like the AAP and CDC offer great guidance too.
They do. It's all about layers of protection.
Okay, so let's try to wrap this up. Key takeaways from our deep dive. Drowning is about respiratory impairment from liquid. Correct terminology matters. Ditch the old terms. It's a massive global issue.
Risk factors are clear supervision, swimming ability, alcohol, medical conditions. The pathophysiology is a rapid cascade leading to hypoxia.
Immediate bystander CPR, starting with breaths, is vital. Medical management focuses on oxygenation, ventilation, supportive care, and managing organ-specific injuries and hypothermia.
And crucially, most drownings are preventable through vigilance and safety measures.
So hopefully for everyone listening, this gives you a much deeper, more accurate understanding to bring to any conversation about drowning.
Which leads us to a final thought, maybe something to mull over. Given how preventable most of these incidents are, what kind of bigger picture changes, systemic things, community initiatives do we think could really move the needle and significantly reduce these tragedies?
That's a really important question to consider. Food for thought.